Welcome back. I hope you all enjoyed your tea. Next, we have a plenary lecture on substance misuse and forensic mental health, which will be conducted by Dr. Danny Sullivan, Executive Director of the Clinical Services, Forensic Care, Victoria.
And I would like to cordially invite Dr. Jan Mendes and Dr. Azri Rodrigo to chair the session. Over to you, sir.
Thank you. I have the delight to introduce my current boss, actually. So Danny is the consultant psychiatrist and the executive director of clinical services of Forensic Care Victoria. And so he also holds academic positions at the University of Melbourne and Swinburne University. And he has 3 master's degrees from University of Melbourne, University of Monash, and University of McGill in Canada in medical law, bioethics, and management. And Danny would be talking to us about substance misuse and forensic mental health. Over to you, Danny.
Thank you very much, Dr. Rodrigo. You can continue employment, which is very good to see. I'm talking about another cheerful topic about substance use and offending. And this is, of course, of relevance to all of us, not just as psychiatrists, but also as citizens, because anything that can reduce offending is going to improve the health and well-being of our societies. In forensic mental health, we always find the conjunction of personality disorder, substance misuse, and mental illness associated with offending. And I suppose it's really difficult to unravel some of the associations, and once more I'm going to draw on the work of Sina Fazel's work at Oxford to explore some of the linkages between those. COVID has taught everyone how to be an epidemiologist, so everyone knows a bit of the language, but I want to reflect a little bit about how it is that we attribute various behaviours to particular mental conditions. Our patients often say things like, I was self-medicating with alcohol, or it was the voices that made me do it. But of course, those are very simplistic attributions, and the reality is a little more complex. So, without putting the horse before the cart, we always need to be sure that we use the correct language in talking about associations and correlations, rather than making unverifiable assumptions about the particular cause. Often that's just a retrospective attribution which seems convenient, and it often reflects, as much as anything else, our countertransference. Patients to whom you are sympathetic will often engender some sort of exculpatory explanation, something which removes blame from them, and patients to whom you have a hostile or a negative countertransference, you will often find blameworthy. So the possible relationships we see, particularly with substance use, so that the substance use can cause the mental disorder. It could cause mental disorder in those who are predisposed, and I'm reflecting on yesterday's debate about legalising cannabis, because for most people that will simply make them boring and put on weight, but for a few people it will make them crazy, and some of those people will cause serious problems. In some cases, I know the term isn't really used anymore, but people in the early stages of developing a mental disorder will use drugs due to perhaps a shared causation. And then finally, we also know that there are some mental disorders which lead to increased drug use. I'm always struck by the statistic that in Australia, which has very successfully reduced nicotine smoking rates to around 15%, that the rates in people with schizophrenia are 85%. So that, again, figure that was shown yesterday, our patients are spending a huge amount of their disposable income on tobacco due to something obviously about the brain of a person with schizophrenia which has a different response to nicotine or a different capacity to cease using it. So some of these will demonstrate that in fact substance use is a confounder, so it looks like the mental disorder but is not, or a mediator, that it's a step along the pathway of causation. So let's try and unravel some of those links. This looks like your beautiful freeways, empty of traffic, smooth driving. The first I mentioned was personality disorder, and of course in the last 20 years we focused a lot on psychopathy as a subset of antisocial personality disorder. And of course the features of psychopathy which predispose to offending tend to be the ones which overlap much more with narcissism. The antisocial behaviours aren't so relevant, but the narcissistic ones we find are strongly associated. And if we look at that association, firstly, some research from the Swedish groups in the past, what this shows is that in both forensic patients and prisoners, the presence of psychopathy is a strong independent risk factor for offending and for reoffending. So this looks at the number of offences, and it shows that people with schizophrenia and substance use offend less than people who have the combination of those with psychopathy. So which substances are relevant to offending? The ones which we see predominantly in Australia at the moment are stimulants. So methamphetamine is the main association with offending. And I'm old enough to remember when that first became a factor. Our heroin usage rates declined quite significantly, and so there was a reduction in the acquisitive offending associated with that. But methamphetamine, often in conjunction with benzodiazepines such as alprazolam, both engendered aggression and amnesia, and you would have prisoners talking to you saying, "I've seen the video evidence, it was definitely me that did it, but I have no recollection whatsoever, and it's right out of character for me, doctor." Some of the other sorts of drugs can be relevant to offending, but I want to focus a little on the main drugs which are perhaps relevant here. Now, if we look at this particular association with disordered mental states, obviously more pluses represents a greater association. Alcohol being the main offender for people who end up in prison with serious offending, not really associated with psychosis, but obviously associated with not so much a mental disorder, but executive dysfunction, disinhibition, impaired judgment. Cannabis, not so strongly associated with offending except when mediated through mental illness. I put in nicotine as relevant because if our patients smoke nicotine and come into prison, it's going to affect the metabolism of antipsychotic medication, and it's also going to affect the capacity to comply with medication when in the community in the future. So nicotine is, of course, relevant, and we always have to remind ourselves to register it as a diagnosis, that nicotine dependence is not something which is simply the norm or something which doesn't record a diagnosis. If we record it as a diagnosis, it encourages us to engage in brief interventions to address it as a disorder which is going to cause the death of most of our patients. I meant to put in at the bottom opiates, and that's because opiates of themselves don't seem to engender mental states associated with offending. They don't seem to be associated with violent offending or sexual offending. They're certainly associated with acquisitive offending to fund the substance use, and they're associated obviously with dealings in the drug world which are associated with offending. So the sort of possible mechanisms by which substance use is linked to offending are, just as I said, that it can be used to fund the substance use, that it can induce a mental state which is associated with offending, that it leads you to affiliate with other people who are using illicit substances and who consequently are likely to have antisocial personalities, but also that it estranges you from society. You end up marginalised, potentially homeless, cast out from your family, and a lot of the strong protective social factors are no longer present. Alcohol being the main particular offender, this gentleman is never successful. So thinking about the substance that you're reflecting upon, the mental states are associated with particular links to the use of substances, either intoxication or withdrawal, triggering a particular episode of mental illness, substance-induced psychosis itself, and then causing other mental disorders, including cognitive impairment due to prolonged substance use. And as I said before, the association might be straightforward, but at the end of the road, all paths lead to the same sorts of altered mental functioning, particularly affecting executive dysfunction. When I worked with sexual offenders, I always used to marvel at how it was that one episode of sexual excitement was clearly something that was so worthwhile to the offender that they would sacrifice years of liberty. And obviously that's not a rational judgment. People aren't simply weighing up the pros and cons. Will this little burst of dopamine release and an episode of sexual satisfaction, is that worth the risk of 20 years in prison and being expelled from my family? Most people wouldn't obviously make that as a rational decision. Let's look at some of the adverse outcomes then from substance-using populations who have particular mental disorders. So here we see that the odds ratios for adverse outcomes, and this includes violent offences, it can include premature death, and you can see that the odds ratio is markedly increased for schizophrenia, particularly for women. The sorts of adverse outcomes are really significant. So we're talking premature mortality from any cause, we're talking about significant violent offending. And as I said in my previous talk, the association with schizophrenia and violent offending is enormous. Much of that offending happens within the family and isn't brought to the attention of police. Much of it is also disordered offending, which was predictable perhaps by the community team looking after the person, in that they saw that they had a small cohort of people that they thought were at escalated risk, but they couldn't detain them preventively, and they couldn't pick which of those people would go on to commit a particular offence. In terms of prisoners, this is simply looking at substance use and outcomes for a group of prisoners. It's again a systematic review and meta-analysis, and it takes prisoners as the category. So the association of violence with alcohol and drug use compared to people in the community is 2 to 3-fold. Many of these seem sort of pretty straightforward. It doesn't seem to be a spectacular fact, but of course we do need the science to confirm our hypotheses and to determine indeed how we shift our policy. Do we shift our policy towards compulsory mental health treatment for more patients? Do we shift our policy towards sustained alcohol and drug treatment for patients? If you had to choose between those interventions, you'd like to base it upon the science to work out which is most likely to reduce offending rates. This was a really elegant study in a large Scandinavian cohort in which each person with schizophrenia was matched with a sibling who did not have schizophrenia. So obviously that controls for many of the influences from the family of origin, for socioeconomic status, for educational level. And compared to their non-affected siblings, you can see that the odds ratio that you're likely to have schizophrenia is significantly increased, and then it's increased even more with substance use. So substance use itself appears to be a more potent contributor to offending than schizophrenia alone. If we look at reoffending rates with substance use, so here the reoffending rate is taken with schizophrenia as the baseline, and then you look at people who, in addition to schizophrenia or compared to the people with schizophrenia who have a different disorder, including substance use. And so what you can see here is that the substance use disorders and personality disorder appear to be the most strongly associated reoffending risk compared to schizophrenia. So if schizophrenia's baseline rate is 1, the elevated risk is significantly higher, to almost 1.5 to 2 times the rate. So what that means, of course, is that when we're looking at our cohort of people in prison with schizophrenia, the ones with the substance use problems are the ones that you really want to focus your efforts on. And you also figure that it's not simply sufficient to treat schizophrenia if you don't also treat the substance use and regard that as an ongoing treatment goal. In Australia, that's often problematic because in the 1980s, mental health and drug and alcohol services parted ways and have different oversight, different funding streams, different workforces. And as a result, you have to knock on 2 doors to get your treatment. It's really hard to knock on 1 door and find someone to get your treatment. Fortunately, I think most psychiatrists who work in forensic mental health have a strong understanding of substance use, are usually proficient in brief interventions and know how to prioritise those. But it is, I think, a core part of forensic training to have a good working knowledge of substance use. And then finally, we look at rehospitalisation rates. So for forensic patients, using schizophrenia as the baseline, the population with substance use was much more likely to be rehospitalised. And interestingly here, if you look at the lowest line, personality disorder was less likely to be hospitalised compared to someone with schizophrenia alone. So the substance use there remains a really strong contributor to rehospitalisation rates. Now, this next image looks a little bit busy, but I just want you to think about this as a developmental trajectory for an ordinary person. And some of the people we went to school with, went to primary school with, grew up in the same area as, go on to develop mental disorders. As you know from your own experience, you can't predict who those will be necessarily in childhood. But going from the top, we know that there are associations with the number of adverse childhood experiences. We also know that there's overlaps with developmental disorders. It's likely that those impact upon retention in education, and it's also likely that those adverse childhood experiences as well lead to maladaptive personality traits. The combination of these is also likely to lead to other forms of psychosocial adversity, which tends to reduce the number of protective factors that I've spoken about, being maintained in your family, having stable accommodation, having employment. All of these are factors we know that reduce the likelihood of offending. As a consequence, you can see that the pathway leads you to affiliate with an antisocial peer group. And then in the population who develop mental disorder and substance use, we know that these are more difficult patients to like. They don't attend their appointments, they're rude and surly, and so that population is perhaps more likely to be rejected from services or to fail to receive effective follow-up compared to a population who are pleasant to deal with, take their medication and appear gracious. They're not fulfilling the patient's part of the deal. So again, it's incumbent upon us in forensic mental health to deal with that countertransference, to maintain our professionalism and to focus on how it is that you offer treatment to people who are sometimes unpleasant and difficult. I've talked about the need to use evidence to inform policy, and I think that's a really great opportunity you have here to drive services in the direction that you want. When we think about this pyramid of public health interventions, thinking that what we're dealing with in forensic mental health is the top. We're dealing with people who have already committed their offences and we're watching the horse running down the road, the stable door is wide open. Ideally, we want to be dealing at the second level, which is where you pick people who have the risk factors you know that are associated with future offending risk, and you're intervening preventatively. And I'll talk about some of those interventions in very straightforward terms. And then, of course, the Holy Grail, what we'd really like to be doing is dealing with it at a primary level, picking children who were at risk, picking juveniles before they were offending, and providing interventions which actually changed their trajectory away from offending. And I think most who work in child and adolescent psychiatry are very strongly motivated by that wish to perhaps alter the trajectory of significant numbers of young people and direct them into better lives. The sorts of interventions which are effective, and we're thinking here about the tertiary for people who have already committed offences. The first is obviously secure detention, and the two things that doctors always say when they work in forensic mental health is firstly that they have enough time to develop relationships with patients, to reflect upon them, to think about them. They're not simply rushing them in and out and filling out discharge paperwork and looking at the building queue in the emergency department, so that's really important. And that's also, of course, associated with protracted periods of compliance with medication. And we all see patients who don't get better in a day or a week or a month. They don't get better in a year. Sometimes it takes 3, 4, 5, 10 years of sustained medication before there's a real shift in attitudes. Now, maybe that's confounded by ageing, but in many cases we really just see that the symptom reduction takes a very long time. So long-acting injectable medications are really critical in forensic mental health, as is clozapine. At our service, we have around just over 40% of our patients are on clozapine. For a lot of people looking from outside, they say, well, it's an oral medication, how can you trust the patient to take the medication? But patients that take clozapine tend to report increased satisfaction with it compared to other medications despite its adverse effect profile. And the reason that they say that is because of the improvement in mental state, reduction in violence, reduction in distressing psychotic symptoms. I was on a ward that Dr. Rodrigo manages, and seeing a man who 2 years before the police were being called, he was naked and on the rooftop holding siege, and instead you could sit down with him and have a pleasant conversation, he could have a bit of a chuckle about his previous behaviour, and it was all due to clozapine, and perhaps Dr. Rodrigo's excellent ministrations. The other evidence, of course, is for substance use interventions. I mentioned earlier long-acting buprenorphine. So this has been a real shift. When COVID hit in New South Wales and the prisons were locked down and all visits stopped, people's sources of illicit buprenorphine, which was smuggled in by visitors, disappeared, and it coincided with the rollout of the long-acting injectable buprenorphine. Substantial numbers of prisoners who had either come into custody dependent or who had developed their drug dependence in custody switched on to the long-acting injectable buprenorphine, and that was, I think, a real shift, because those people will go out into the community, their risk of death from overdose will be reduced, they will remain engaged with services in order to obtain their medication, so you have an opportunity for health promotion, and of course you reduce all of the offending associated with seeking to obtain your opiates. It also appears to have some action in reducing craving for other substances, probably through a dopaminergic effect, but that means that for people with severe alcohol dependence, cannabis dependence, methamphetamine dependence, there appears to be it hasn't really been verified in the research literature, but certainly subjectively, some patients report a significant reduction in their craving for other substances. Other offence-specific interventions are also really critical, and there was after the British Probation Service revealed staggering data showing that there was absolutely no benefit in reduction of future offending for sex offenders undergoing sex offender treatment programs, so 250 hours of intervention. A further meta-analysis by Therese Gannon showed that there was indeed a positive effect size, but only when the group was led by a trained psychologist, not with other group leaders. So addressing other treatment targets such as substance use and personality disorder also appears worthwhile, but perhaps not as much as the others. And then finally, when a person returns to the community, the capacity for assertive community management by nursing staff who are trained in following up patients and ensuring compliance. For the secondary interventions, for those where we figure that there are targets which we could meet in a larger population, the main intervention that's really critical is that prison screening, is being able to select the population in the first place. And also, as was mentioned yesterday in the excellent talk on motivational interviewing, enrolling the patient as a collaborator in the enterprise, not in directing them, not in telling them what to do. Of course, you always have coercive frameworks, but actually making sure that you can bring them on board to join in. And then, of course, we have mandated treatments either through correctional systems or through mental health systems, which engage people in treatment and during the period of engagement appear to reduce offending risk. The final interventions are those primary health ones, the ones at the most basic level. Again, you can pick through prison screening people with other disorders which might require intervention. You can hopefully divert people from prison in the first place. But in fact, what you probably want to do is spend your money not on healthcare, but on a whole range of other issues. And if there's one fabulous publication, one of the best plain language, almost a philosophical publication. This was published by the Chief Scientist of New Zealand in 2018. It's publicly available on the internet. And it's a plea for justice reinvestment. It's saying prison is not working because people keep reoffending and coming back. We're detaining huge numbers of young people, and in New Zealand, Maori people, Indigenous people, and we don't want to be doing that. So this was actually a plea to take all of the money from prisons and instead plough it into special targeted education for children who are at risk of falling out of the education system, supporting families who aren't managing parenting well, nutrition and health advice for children, pathways to vocational employment for people who otherwise would be unemployed. All of the money that we spend on prisons, we could reinvest in these health interventions, public interventions and policy interventions which might actually reduce the need to treat offenders in prison. Thank you very much.
Thank you, Danny, for that very elaborative speech about substance use and forensic mental health. And substance use has been a major problem in Sri Lanka, and this city itself has a huge problem of drugs and alcohol issue. This is Negombo city. And we will open your presentation for a few questions. Yeah, Amila.
Thank you very much for that very elaborative presentation. So I have a bit of a practical question, and so you address the broad area of the substance misuse in prison population. So most of the time when people with substance misuse admitted to the prison temporary or for some time, they experience withdrawal symptoms, for example, opioid and other psychoactive substances. How do you manage that in your setting?
The way in which withdrawal is managed in a prison setting is usually would not meet the standards of primary health care. But typically it's managed with a combination of Panadine Forte, which is paracetamol, and 60 milligrams of codeine, and 10 milligrams of diazepam, given 3 times a day, 2 times a day, and once a day for 3 days. So for people withdrawing from methadone, for instance, that's clearly insufficient. For people withdrawing from alcohol, it probably is sufficient for some, but for people with severe substance dependence who are at risk of withdrawal seizures and withdrawal delirium, it's insufficient. So again, in terms of screening, if you screen for that population at the beginning and you pick the ones who might be at greater risk of a complicated withdrawal, whether through physical health problems or the magnitude of their substance use, you can then direct them either into a medical unit for a medically supervised detoxification, or you can put them into the mainstream and give them the standard detox.
Right.
Having said that, the reception centres in most Australian places are full of people withdrawing from substance use, so they're very miserable places to be.
Right, thank you. And how about using tramadol and gabapentin in your practice?
Sorry, Panadol and...
Tramadol and gabapentin.
No.
You don't use? Yeah,
No,
thank
it's,
you.
it's very rarely used. All drugs which are prone to abuse by prison populations are very tightly policed. So everything from tramadol to pregabalin to all of the other medications, you really have to lie very convincingly or be close to death to be provided any of those sort of interventions.
Thank you so much.
Any other questions?
I have one question, Danny. Yeah, like in your formulation, actually something that was missing from Sri Lankan context is family. Like family plays a huge part here, mostly protective, at times not so protective. Do you have any thoughts on like how it would kind of incorporate into that formulation?
Certainly. Look, I would draw family into various elements. Firstly, the community reintegration. Secondly, the assertive case management, because assertive community management involves the family as an early warning system, as people who monitor compliance, and as people who offer a range of alternatives to an offending lifestyle. And then thirdly, when I spoke about collaboration, that involves the family as well. So we recognise that the family are perhaps, our greatest allies, and that maintaining relationships for prisoners who come into prison, maintaining relationships with families, repairing relationships with families, and building them up is really critical. Yeah. One of the really sad statistics that I've always remembered in Australia is that if your father is in prison, you are 6 times more likely to be imprisoned than someone in your class whose father is not in prison. Now, whether that's because you become familiarised with prison, whether that's a place that's to be proud of going to rather than to be deterred by, or whether in fact there's a range of other family constellation problems that are associated with that. But we all know that if you have 2 children sitting in class and you can identify one of them as at increased risk of going to prison because his father's in prison, you've got 2 choices. Don't put his father in prison, find an alternative. Or number 2, target that child and give him or her more opportunities. Take up the opportunities which perhaps the family is not able to provide to give that child a better chance.
Thank you very much. Any other?
Probably because of time, we will stop there. So Dr. Jan Mendis will appreciate your contribution. Thank you, Danny.
Next, we will be having the free paper sessions. I would like to kindly call upon Dr. Gayani Sirivardhana. Dr. Samir Dasanayaka will be chairing the session.
Okay, so it's the time to start the second free paper session for the day. We have had 5 presentations lined up, but unfortunately one presenter who had authored 2 papers had not turned up due to unavoidable circumstances, so we are left out only with 3 presentations. As you are probably aware, you have 8 minutes for the presentation, followed by 2 minutes for the discussion. So I would like to remind very kindly to all the presenters to try to stick to the time frame as much as possible. As you go along, our panel of judges will do a very diligent job of very meticulously evaluating you. So good luck. Over to you, Samira, to initiate with the first presentation.
The first presentation of the second session will be done by Dr. Nipun Ranavira, and the paper will be on prevalence of depression and its associated factors among the primary caregivers of patients with psychiatric illnesses attending psychiatric clinics in the Hambantota district. Over to you, Nipun.
Thank you. Good morning, ladies and gentlemen. The prevalence of depression and its associated factors among the primary caregivers of patients with psychiatric illnesses attending psychiatric clinics in Hambantota district. Being diagnosed with a severe psychiatric illness is a life-changing event not only for the patient but also for the whole family. Long-term caregiving of the patient with severe mental illnesses require great dedication. It may lead to compromised physical, psychological, and social well-being of the caregiver. Global studies show that the caregiver of the patients with severe mental illnesses have higher rates of depression when compared with the general population, usually two times that of the general population. There were only 2 studies done in Sri Lanka on caregiver strain and the depression in major mental illnesses. One of the studies was carried out in urban setting, including 85 caregivers, that is in National Hospital Sri Lanka. And this study showed that the symptoms of depression were significant in 37.5% of caregivers. Aim of our study is to estimate the prevalence and associated factors of depression among the primary caregivers of patients with schizophrenia, bipolar affective disorder, major depressive disorder attending psychiatric clinics in Hambantota district. This study was conducted as a descriptive cross-sectional study, and there were 14 psychiatric clinics in Hambantota district. Only 12 clinics were functioning at the time due to the health policies during the COVID-19 pandemic. And these were the clinics we gathered data, 12 clinics. 180 caregivers who fulfilled the inclusion criteria recruited to the study. Caregivers were interviewed by trained data collectors with an interviewer-administered questionnaire for demographics, socioeconomic standings, patient illness-related data, and adverse effect on caregiver due to their role. The questionnaire was developed by the principal investigator using previous studies after discussing with relevant experts. GHQ-12 and PHQ-9 were used as the last 2 items of the questionnaire, and so the caregivers were screened for psychological distress with GHQ-12, and those who became positive for GHQ-12 were again assessed with PHQ-9 for depression, and those who became positive for PHQ-9 were clinically assessed by a consultant psychiatrist to confirm the diagnosis. Results. In patient population, a majority, that is 69% of the patients had the diagnosis of schizophrenia, followed by bipolar affective disorder and major depressive disorder. 51% of caregivers were female. Caregivers' age ranged from 18 to 81 years, and the mean age was 55.5 years. 87% of mentally ill patients and 50% of the caregivers were unemployed. And 58% had their monthly family income between 5,000 rupees to 25,000 rupees. And in 15% of the families, monthly income reported to be less than 5,000 rupees. 45% of all caregivers admitted that they need psychological support from someone, and 90% were dissatisfied with the financial and other supports received from the government. However, 94% were satisfied regarding the care they received from the local mental health team, and 74% of the patients did not have any admission to psychiatric facility during last year, and 84% had good overall medication compliance. The prevalence of depression among the caregivers of the patient with severe mental illness was 19.4%. It was revealed that the female gender, older age, presence of physical violence, and beetle chewing were associated with caregivers' depression. Female gender, age above 50, beetle chewing independently predict caregiver depression following binary logistic regression analysis. Conclusions. The prevalence of depression is high in caregivers of patients with severe mental illness. 1 in 4 female caregivers found to be depressed. Female gender, age above 50, and the beetle chewing independently predict caregiver depression. The findings of our study were comparable to the finding of the studies conducted in Ethiopia, Saudi Arabia. However, the rates are lower than China, India, and USA, California. This study illustrates the importance of screening of caregivers for depression. A special focus should be given to the primary caregivers who are above 50 and female caregivers. There's a necessity for the development of social support services to ease the burden of the families with mentally ill patients in rural Sri Lanka. There are some limitations of our studies. Our study is a cross-sectional study, therefore it's very difficult to establish a cause-effect relationship. The study was carried out during the COVID-19 pandemic of Sri Lanka. So obviously the financial and social effect of the pandemic might have played a role. Therefore, I have to be cautious when we are generalizing the results. There are certain strengths in this study. Unlike most of the studies, outcome measure of our studies, the clinical depression established by a consultant psychiatrist. Moreover, this is the first study to look at the caregiver's depression in Sri Lanka in a rural setting. Certain factors surface in this study, such as high unemployment rate of the patient and the caregivers, the high dissatisfaction rates towards the government supports, sends a strong message to the policymakers. Thank you very much.
Now the paper is open for questions. So we have 2 more minutes.
Yeah, just this observation of beetle chewing being associated with caregiver distress or depression. What is your opinion on that?
Yes, again, as I said, since this cross-sectional study is very difficult to see a cause-effect relationship. However, in previous studies, it has been reported that the recent study, like 2020 study, the prevalence of depression is high among people with the habitual beetle chewers, like 26%. But however, this is the first study to look at the caregiver population. So I haven't found any studies done in like involving beetle chewing in caregiver population.
For the questions, we'll move to the next presentation.
Okay, the next presentation would be a randomized controlled trial of a mindfulness-based online intervention to reduce stress and improve well-being among healthcare workers during the COVID-19 pandemic, which will be presented by Dr. A. Baminiwatta. Over to you, Dr. Baminiwatta. Good luck.
Thank you. Good afternoon, everyone. I'm Anuradha Baminiwatta, and I believe our study is quite well aligned with the main theme of our sessions, Healing the Trouble During Troubled Times. It's titled A Randomized Controlled Trial of a Mindfulness-Based Online Intervention to Reduce Stress and Improve Well-being Among Healthcare Workers During the COVID-19 Pandemic. Let's first look at the background that led us to conceptualize this study. Globally, there was mounting evidence on the preponderance of mental health issues among healthcare workers, and meta-analysis estimated, for example, the prevalence of depression and anxiety to be close to 40%. In Sri Lanka, even higher rates were reported at certain centers, and at our center in Colombo North Teaching Hospital, we observed in a study that preceded this trial that more than 1/5 of the healthcare workers exhibited significant levels of psychological distress. So there was a tangible need for an effective, feasible, and acceptable intervention to safeguard the mental well-being of healthcare workers. Mindfulness-based interventions have a large evidence base supporting their efficacy. And we know that mindfulness is a concept and practice that is quite close to our culture. So we believe that a mindfulness-based approach would be acceptable to the target community. And however, mindfulness-based interventions had not been evaluated in a randomized control design or among healthcare workers before in Sri Lanka. And also we opted for the online format because of its many advantages. We know that online interventions are more accessible, participants can join in from their own environments, and they save the time and cost of traveling as well. And also during the COVID-19 pandemic, the restrictions on physical gatherings also made this the more preferable approach. So we set out to evaluate the effectiveness, feasibility, and acceptability of an online mindfulness-based intervention in reducing stress and improving well-being among healthcare workers. Our protocol was pre-registered in the Sri Lanka Clinical Trials Registry, and ethics approval was obtained. Our participants were recruited from 3 tertiary care hospitals in Sri Lanka. Our participants were healthcare workers of any category, aged 18 or above, and able to access internet at home. However, we excluded those who could not understand Sinhala, those who were receiving concurrent psychotherapy and other forms of psychotherapy, and those in whom psychiatric treatment had been commenced within the last 3 months. Shown here is the consort diagram of our participant flow. Our sample size was 80, and we randomly allocated these participants into 2 groups as the intervention arm and the waitlist control arm of 40 each. And the intervention arm went through the intervention over 6 weeks, while the other group served as the control group. And thereafter, the waitlist control group also went through the same intervention. If you look at our intervention, it was mainly an adaptation of the mindfulness-based stress reduction program developed by John Kabat-Zinn, but with elements of mindfulness-based cognitive therapy and compassion-based practices as well. And each week, the group gathered for an online session lasting for 1 hour. And over the next week, the participants were encouraged to do home practice of mindfulness-based exercises at least 20 minutes per day. The primary outcomes that we assessed at the beginning and end of the trial were stress, as measured using the perceived stress scale, and well-being, as assessed using the WHO 5 index. Additionally, we also assessed the acceptability and feasibility of the intervention. We tested the effectiveness of the intervention using ANCOVA models in both intention to treat and complete case analysis, and the corresponding effect sizes were calculated. Shown here is a comparison of the socio-demographic characteristics in the 2 groups, and we found that the 2 groups are similar with regard to the socio-demographic factors, and there was a female preponderance in the sample, and also the sample mainly consisted of nurses and doctors. Now coming to the main results, you can see here in this diagram the effect on well-being. So there was a marked improvement in well-being in the intervention arm compared to the control arm, and this difference was statistically significant. On intention to treat analysis, this translated into a medium effect size, whereas on complete case analysis, this meant a large effect size. Then with regard to the effect on stress, you can see a reduction in stress levels in both groups, but with a steeper reduction in the intervention arm. However, this difference did not reach statistical significance. On both ITT and CC analysis, this was only a small effect. If you look at the feasibility and acceptability of our intervention, the median number of sessions attended by participants was 3, And at the post-evaluation, out of the 22 who responded, 21 said they liked the intervention, 22 said the meditation recordings that were made available were very useful, and 21 said they found the techniques easy to practice. One of the main questions that arose from the findings was, why did well-being improve without a change in stress levels? So there could have been several reasons. One thing is, we know that well-being is now conceptualized as a positive affect state rather than mere absence of negative affect states. And also we know that other mental health problems like depression and anxiety could have contributed to well-being. However, in our study we have not assessed whether depression and anxiety changed over the trial. And also in our 6-week intervention, the fifth week was spent on developing self-compassion, which we know is linked to well-being. So the proximity of the compassion-based practices to the post-evaluation could have contributed to these differential effects. One of the main strengths of our study was that it was adequately powered with an adequate sample size. And however, there were several limitations that we may need to address in future research. The sample was overrepresented by females, and the retention rate at the end of the trial was rather limited. And also depression and anxiety were not assessed. And finally, mechanisms of action, why well-being improved, could not be established in our study, but that was particularly because we didn't have validated instruments to assess certain constructs like mindfulness and self-compassion at the time of conceptualizing this study. So in conclusion, our online mindfulness-based intervention was found to be effective in improving well-being among healthcare workers with a medium to large effect size. However, the improvement in stress was not statistically significant. That concludes my presentation, and these are some of the references I have used.
Now, the question is, why do you say that it was mindfulness that was effective? And why couldn't it have been just a gossip session every time you met with them? Because the other group was a wait list control, wouldn't have any effect. So it could have even been the placebo effect that brought about the positive reduction in stress.
So in our intervention, it was although as it was an online intervention, the participants did not have the opportunity to interact with each other. So I think the gossip part did not factor in here. But of course, since this is a difference from the waitlist control group, they are gathering together and they might feel connected with other people. So that I agree that it could have definitely contributed to the effect that we've seen with regard to well-being. And also, as I mentioned, we have not assessed the mechanisms of change. So it would have been better if we could have assessed whether an improvement in mindfulness mediated the effect of this study. So at the time of conceptualizing this study, we did not have a validated instrument to assess self-reported mindfulness. So if we had been able to do that, we could have shown whether an improvement in mindfulness is exactly what's causing this change in well-being.
And can you also explain to us the online intervention? Was it administered, or were the sessions monitored or whatever by a therapist, or was it something they did on their own during their free time?
It was done live, so the participants joined in live to the sessions, and certain level of interactions happened between the therapist and the participants. But other than that, it was done mainly on live. So and also we provided them with recordings of the Zoom sessions, so they could have gone through the sessions later on as well. But it was mainly done live.
Yeah, Dr. Beminatha, thank you so much for that very inspiring piece of work. So we as psychiatrists, we have to be really proud of people like you and taking this research in psychiatry to another level. Thank you so much for that. And have you, especially because healthcare workers, when they are distressed or depressed, they are not seeking evidence-based medicine because of a stigma and so many other things. So in that way, your intervention is really, really helpful, because we have seen lots of them are not coming to evidence-based medicine, and when it's online, and so they can access on their own and they can get the help. So that is really a positive point I see in that. So have you, my question is, have you tried before administering this, the intervention, did you get their viewpoint about this intervention? What are the difficulties? What are the strengths and weaknesses? And how would you improve on that? So if you can get some kind of feedback, you could have improved this further and add few things to get the maximum benefit of it.
You mean at the end of the trial or
before you do that?
Yes, we have not asked about their opinion on how to administer this, but we have provided them with the necessary information regarding what we are going to do. Yeah. And also we have given them the other options like seeking help from a psychiatrist if their symptoms are so distressing. So we have given them the relevant information about other available means of getting help as well. And after explaining all these, only we recruited those who were willing to take part in this 6-week interventions.
Yeah, thank you. That's not my question. The acceptability of your intervention.
Yes. We have assessed the acceptability at the end of the trial only, sir, not at the beginning.
I'm suggesting if you do that beforehand, you could have get better results.
Yeah, right. That is something we can do in future studies.
Thank you so much. Anyway, really good one.
Were doctors.
Yes.
Were they aware of mindfulness? What is the awareness? So did some of them have perhaps taken some interest and started practicing? What is the deal there?
Yes, madam. What we experienced was many of those who joined had some exposure, like they knew what mindfulness was about. So that's why I think they were attracted to this. But they had not, most of them had not been practicing it really, but just heard that there is something called, practicing mindfulness. Yes.
Right. Since we are running out of time, we will conclude that and then we will move on to the next presentation. Thanks.
The last presentation of the session will be done by Dr. S.A.T. Harini, and it is on prevalence of post-stroke depression, its relationship with functional ability and some selected associated factors among stroke survivors in Sri Lanka during early rehabilitation, a cross-sectional study.
Good afternoon. I'm Tamisha Harini and I'm a physical therapy student from the University of Colombo. Today, I'm presenting our study, the prevalence of post-stroke depression, its relationship with the functional ability, and some selected associated factors among stroke survivors in Sri Lanka during early rehabilitation. So, post-stroke depression or PSD is the commonest psychiatric complication that occurs following a stroke. Although the consensus is that approximately 1/3 of the stroke survivors develop PSD, a wide variations in the prevalence is reported in the literature. The variability between the results of these studies depend on the assessment and diagnosis of depression as well as the population they studied. The post-stroke depression has a significant negative impact on rehabilitation. Therefore, identifying PSD prevalence and its associated factors during the initial rehabilitation promotes early detection and treatment of PSD, which will lead to positive outcomes in post-stroke rehabilitation. The specific objectives of our research are to identify the prevalence of post-stroke depression in patients with stroke during the initial 6 months of rehabilitation, to find out whether there is an association between the severity of depression and the functional ability, and to identify the associated factors for PSD. So we carried out a cross-sectional descriptive study at the Rheumatology and Rehabilitation Hospital Ragama, and the patients who have a diagnosis of a stroke with a post-stroke duration of maximum 6 months attending the rehabilitation program at Department of Physiotherapy were selected as the study population. Data were collected from 70 participants through a consecutive sampling method by using culturally validated self-administered questionnaires. They are the Patient Health Questionnaire 9 to diagnose depression and the Lawton Instrumental Activities of Daily Living Scale to measure the functionality. A semi-structured questionnaire was also given to collect the demographic data, and the data were analyzed by SPSS version 23 software. Results. Characteristics of the sample. So, out of the 70 participants, 39 were male and 31 were female, and participants of ages between 33 to 79 years from Gampaha, Colombo and Monragal district participated in this study. Prevalence of post-stroke depression. The PHQ-9 scores for depression in the study sample ranged from 0 to 17 with a mean PHQ-9 score of 7.16. 74.3% showed any form of depression in the study sample, and 45.7% were mildly depressed. Functional ability and the post-stroke depression. The IADL scores for functionality level range from 0 to 8 with mean value of 3.41, and a negative correlation between the functional ability and post-stroke depression was identified with the Pearson's correlation test. In our study, age, gender, ethnicity, marital status, employment status before the stroke, educational status, involvement of the dominant side, and previous stroke were evaluated as possible associated factors for PSD. Only female gender, employment status before the stroke, involvement of the dominant side, and previous history of stroke were identified as having significant association to the PSD. This study reports a 74.3% of high prevalence rate among stroke survivors attending early rehabilitation. The overall prevalence of PSD is relatively high compared to the pooled evidences in the systematic reviews. However, only 28.6% had major depressive symptoms that are in concordance with similar previous study findings. The negative correlation between the functional ability and post-stroke depression was consistent with most previous study findings. Female gender, involvement of the dominant side, history of previous stroke were common associated factors observed globally, which was confirmed in our study. Limitations. So, the smaller sample size is one of the main limitations in our study, as fewer patients participated in this study due to the COVID-19 pandemic, and the patients were screened primarily to detect the PSD symptoms. However, a further psychiatric evaluation is needed to confirm the diagnosis. The ethnic diversity of the participants failed to represent a Sri Lankan population, as the majority of the participants were from Western Province. So, in conclusion, post-stroke depression is more common among stroke survivors, as 74.3% of the patients undergoing stroke rehabilitation develop PSD, and the prevalence of depression is almost threefold higher in this sample, while the majority of the patients go unnoticed with mild depressive symptoms. Post-stroke depression should be detected early and treated promptly for better prognosis and positive rehabilitation outcomes. Thank you.
Now the paper is open for questions.
Is there anything new from what you found in terms of what is already mentioned in the existing literature?
Most of the patients had mild depressive symptoms, and it is often neglected in the studies, and it might worsen the condition, and it also might affect the rehabilitation process, especially we see as physios in the stroke rehabilitation.
PHQ-9, which had been used to diagnose depression, I'm not sure whether you can diagnose depression simply by PHQ-9.
Yes.
It needs to be supported by a clinical evaluation.
So, since it's an undergraduate study, I only use the rating scale, but it should be further evaluated by a psychiatrist to confirm the diagnosis.
Okay, thank you, Harini. And this will bring us to the conclusion of the pre-paper presentation. And we would like to thank panel of judges, Professor Shahan Williams and Dr. Devashmika Arisinghe. Thank you, sir, and thank you, madam.
Thank you, madam and sir. Now we will be giving away the certificates of appreciation for oral presentations. I would like to kindly invite Dr. Devasmika Arisinghe to give away the certificates. First of all, Dr. S.S. Ratnatunga. Dr. G.R. Sirivardhana. Dr. T. Abhay Bandara Herath. Dr. H. M. N. Thisera. Thank you, madam. Next, I would like to cordially invite Professor Shahan Williams to give away the certificates of appreciation. Dr. S. M. A. N. Samaranayaka. Dr. N. Ranavira. Dr. A. Baminiwatta. And Miss S. A. T. Harini. Thank you, sir.
Next, we are going to give out the certificates of appreciation for the judges of the e-posters and oral presentations. I would like to invite Professor Ranil Abhay to give out these certificates. The first certificate will be going out to Dr. Sajeevan Amarasinghe. Dr. Chathuri Suravira. Dr. Amila Isuru. Dr. Jayamal De Silva. Professor Madhubhashini Dayabandara. Professor Shahan Williams. And Dr. Devasmika Aryasinghe. Thank you. Our final event before lunch will be a plenary on bipolar affective disorder, updates on management guidelines, which will be conducted by Dr. Sajeevan Amarasinghe. I would like to invite Dr. Suhashini Ranatunga and Dr. Dasanthi Akmimena to chair the sessions. Over to you, madam.
Good afternoon. It is my pleasure to introduce Dr. Sajeevan Amarasinghe. I'm sure he's no stranger to any of you all. Just a very brief introduction. Dr. Amarasinghe is a consultant psychiatrist at the National Institute of Mental Health. He is the current secretary to the Board of Study in Psychiatry at the PGIM. Dr. Amarasinghe has been an active council member of the Sri Lanka College of Psychiatrists for the last 8 years. He is also a council member of the SARC Psychiatric Federation, the Ceylon College of Physicians, as well as the Sri Lanka Association of Geriatric Medicine. Over to you, Dr. Amarasinghe.
Thank you, Suhashini, for those kind words. Now, I'm coming into bed half an hour before lunch, and I'm supposed to, I think, finish quickly, but I have been given a bit of a difficult task to update you on the management of the management guidelines of bipolar affective disorder. So this is mainly aiming this at the trainees, and I hope to run through this a bit comprehensively. So I'm looking at 4 main guidelines: the 2014 NICE guidelines, the British Association of Psychopharmacology guidelines 2016, the CANMAT and ISBD 2018, the Canadian guideline, and the newest one, the RANSAP 2020. I'll be looking at how not only the differences in the guidelines, but also how these how guidelines and treatment have changed over the years. And also I'll be looking at it in different components: treatment of acute mania, acute depression, maintenance, and also mixed episodes. And I'll be going fast. If you have problems, we'll maybe take it in the question time. Of course, just for the benefit of the trainees, I can tell you, just to remind you that guidelines are merely guidelines. They're not the gospel truth. And real patients sometimes might need different treatment. But this is for academic purposes. And also, don't think that you need to remember all these guidelines for your exam. It's not necessary. You don't need to know what is first in NICE and what is first in BAP. But I think you might be expected to know the level of evidence for a particular medication in a condition, right? But this guideline, especially the BAP guideline and the new RANSAP, is very useful because it gives a lot of information on bipolar affective disorder, a lot of new papers. If you take acute mania, the NICE 2014 is very simple. If it's not an mood stabilizer, they ask you to start an antipsychotic. The 4 ones that came top on Cipriani's trial: olanzapine, haloperidol, risperidone, and quetiapine. And if not responsive, you can consider adding lithium or valproate. If he's already on a mood stabilizer, which they think is probably lithium or valproate, you optimize the mood stabilizer, and if not responding, add one of the 4 antipsychotics given before. Let's move on to BAP 2016. Again, they divided the same way. If you're not on long-term treatment, it's the same first-line drugs. BAP and NICE, I mean, there are differences, but sometimes this is same in mania. And of course, they give some alternatives, like valproate, aripiprazole. Valproate, they put it down because of the teratogenic risk, mainly in the females. Aripiprazole, lithium, other antipsychotics. Lithium, because it's slow to act, it's not going to be that fast. And of course, on long-term treatment, again, it's the same as NICE. You go for the highest tolerated dose of the current treatment: lithium, valproate, or one of the antipsychotics. If there's a poor response, you add the second medication: lithium plus antipsychotic or valproate plus antipsychotic. If it's refractory, they recommend clozapine or even ECT. CANMAT, they say they are looking at a more holistic picture when they're coming for they're looking not just at acute mania, they're looking at the treatment, preventing mania, preventing depression, preventing the long-term picture, as well as safety and tolerability and the risk of switch. And they have given monotherapy options as well as combination options. The clinician must decide whether we are going for a monotherapy or a combination. So CANMAT, the difference here is the monotherapy options, they're promoting lithium as number 1, lithium, quetiapine, this is the hierarchical order, valproate, and they brought in some of the newer antipsychotics and taken down olanzapine and haloperidol. We'll come to that later. And of course, the combinations are lithium and valproate plus aripiprazole or risperidone. Acetaminophen we don't have. So they have taken olanzapine and haloperidol to the second line, which is the current trend, mainly due to the serious side effects and tolerability issues. And combinations with olanzapine are also considered second line, and the lithium valproate combination is also considered second line. Let's move to the RANSAP. The RANSAP 2020 is the newest one. They prefer monotherapy over combinations because of better compliance and fewer side effects. If it is severe mania with agitation and psychosis, they say go for a second generation antipsychotics, especially with the sedative effect. Mild mania maybe can manage with only a mood stabilizer. And they talk of choices. The first choices, monotherapy. Again, antipsychotics, they are mainly on risperidone, quetiapine, and aripiprazole. Olanzapine and haloperidol downgraded again. Combination choices, lithium and valproate with the first line, lithium or valproate the first line, second generation. Mood stabilizers, lithium or valproate. And it's graphically given here. They are mainly first line choices after the ones we have, aripiprazole, risperidone, and quetiapine. And also they call combinations of a second generation antipsychotic with lithium or valproate. And alternatives are their second line. So as you see, haloperidol and olanzapine gone to the second line, and any combination with olanzapine is also now considered second line. This is in graphical form. So the monotherapies and the combinations, alternatives. ECT is also considered. So just look at ECT in mania. NICE is not doesn't encourage that much. But BAP says severe mania, treatment-resistant mania, and mania in pregnancy. And they all go to say the 60% remission rate in manic patients who had previously responded poorly to lithium or antipsychotic. They use this term dopamine antagonists and partial agonists for antipsychotics. That's the term that BAP uses. So CanMat gives it as a second-line option, and they say 80% of patients will show marked clinical improvement, and they promote bifrontal electrode placement, faster response, and fewer cognitive effects. And RANSAP 2020, again, notes it as a useful option, and they continue to say that bifrontal ECT has a more rapid action. So the duration of treatment for mania, NICE says after 4 weeks, after 4 weeks of resolution of symptoms, to discuss with the patient about long-term treatment. If the patient prefers antimanic, to continue for 3 to 6 months and review. BAP talks about complete revision in about 3 to 6 months. CanMat advises to continue the antimanic treatment, either the second generation or the mood stabilizer, for 6 months. Now, let's go to a more controversial topic, bipolar depression. And I can remember as a trainee way back in 2005 and 6, Dr. Abhay Singh asking us to debate about bipolar depression and antidepressants. So it used to be controversial then, still controversial. Still, these rankings that I'm going to give are very unstable rankings. One clinical trial will change everything. So, and of course, nowadays, they are not only looking at clinical trials and meta-analysis. I think that I should have started at the beginning. Many of these modern guidelines are now taking into account large naturalistic studies that are done. And they say they also give very useful information, not just the meta-analysis. NICE, if you're not on any medication, they promote this fluoxetine olanzapine combination. That's what they're number one. And the other options they give are quetiapine, olanzapine, or lamotrigine. If the patient is on lithium or valproate, again, the advice is to optimize the mood stabilizer, and if there's no response, again, the number one is olanzapine fluoxetine combination, plus the 3 antipsychotics I told earlier. ECT is not recommended in NICE, and of course, they say to offer a psychological intervention developed specifically for bipolar disorder. This NICE recommendation has been heavily criticized in articles as well as in the BAP guidelines. BAP will go 2016. If you are not on long-term treatment, their first line would be a second-generation antipsychotic, mainly quetiapine, lurasidone, or even olanzapine. The best evidence, they say, is for quetiapine, 300 to 600 milligrams. Second option they have given is an antidepressant with a mood stabilizer or a second-generation antipsychotic cover. And there they give the fluoxetine olanzapine combination, which NICE recognizes so highly. And another top option is a lamotrigine with a mood stabilizer. They give a place for ECT in severe or refractory depression, and they consider psychotherapy only as additional treatments. If somebody is on long-term treatment, first option, of course, is to optimize the mood stabilizer or the antipsychotic, if not to add as previously told. So, BAP, there are some interesting points about lithium. They say the evidence in lithium in acute depression is quite poor, but treatment guidelines have repeatedly recommended use of lithium as a first line in bipolar depression. They feel that it may be because of its anti-suicidal effects and prophylactic effects in the long term. They are quite dismissive of valproate, saying it's poor evidence with 4 small trials in acute depression, not prevention, right? If you go to CanMat, the Canadians, their first line option again is quetiapine, 300 to 600 milligrams, lithium, but mind you, they propose a lithium level of 0.8 to 1.2 milliequivalents per liter. And lurasidone with a mood stabilizer, lamotrigine 200 milligrams, lurasidone alone or lamotrigine plus mood stabilizer. Now lamotrigine, again there's a discussion about lamotrigine of some failed trials in lamotrigine. What CanMat and RANSAP says is that lamotrigine trials are of too short duration. By the time they comes up to 200 milligrams, they have given only 2 weeks of 200 milligrams. So that is the reason for some of the failure of some of the trials in lamotrigine, because it's too short duration of the therapeutic dose. CanMat gives valproate as a second line option and also SSRI or bupropion. They are avoiding tricyclics and venlafaxine for obvious reasons, plus a mood stabilizer. So antidepressant plus mood stabilizer. The strong antidepressants, they are not recognizing because of the switch risk. ECT, and of course the DIVA, which is cariprazine, it's also given as a second line option. So when it comes to RANSAP, they say to give mood stabilizers preference over the second generation antipsychotics. So there's a difference between the BAP and CanMat, where they give top priority to quetiapine and olanzapine, where RANSAP says to consider lithium, lamotrigine, and valproate as the top choices. And the second generation antipsychotics, 2 are considered in first line. They are quetiapine, lurasidone, and cariprazine. So this is in graphic form. The mood stabilizers in order of priority: lithium, lamotrigine, and valproate. The second generation antipsychotics, again in the order of priority: quetiapine, lurasidone, and cariprazine. RANSAP generally goes for, in the alternatives, they have given a lot of alternatives and quite complicated: mood stabilizer plus antidepressant combinations, mood stabilizer plus second generation antipsychotic combinations, and also they have given a place for ECT. Now, this question of switching, antidepressants and switching. BAP says to use antidepressant with a mood stabilizer or a second generation antipsychotic to reduce the risk of switch. And they say TCAs and venlafaxine have a very high risk of switching. Now, RANSAP says that it should be case-based decision. If past manic episodes have been very severe, or if the consequences of the manic switch is very severe, not to use or to be very cautious about antidepressants. And they say in some patients the manic episodes have been mild manic episodes, and in that situation antidepressant with combination, of course, with mood stabilizer can be used. Discontinuation of antidepressants. Here again there is a bit of a discrepancy between BAP and NICE. NICE says 4 weeks after resolution of symptoms to discontinue the antidepressant, discuss about long-term treatment. Whereas BAP says to follow the unipolar guidelines, unipolar depression guidelines, which is of course 6 months. And then of course both agree to taper off for 4 weeks. And now we move on to a bit more complicated thing, the mixed episodes. Now, BAP would differentiate the mixed episodes. NICE doesn't talk much about the mixed episodes. BAP says the acute mixed episodes with predominant manic symptoms, we go with a atypical and second generation antipsychotic. They are from the ones we have, olanzapine, risperidone, aripiprazole are ones they are recommended. If there is a depressive episode with mixed features, they are not clear. They say the evidence is not very clear when there is a depressive episode with mixed features. But they are very clear that there is no indication to either start or continue treatment with antidepressant in a mixed state. CanMat again agrees mainly with the same thing, the second generation antipsychotics, olanzapine and aripiprazole, and valproate in a mixed state. Ransap, they note that it's very challenging to treat. Suicide rates are higher in mixed states. And they propose to use medications that are anti-manic, antidepressant, and mood stabilizing. And unlike BAP and CanMat, they prefer lithium and valproate. And to some extent, quetiapine, which is anti-manic, anti-depressive, as well as mood stabilizing. And they reiterate, do not use antidepressants. And olanzapine is given as an alternative, as well as there's a place for ECT. It's given in a graphic form. Lithium, valproate, and quetiapine in the bipolar mixed. If it is mainly mania, predominant mania, to go with aripiprazole. And if it is predominantly depression, to go with lurasidone. And of course, they have given some alternatives. Olanzapine is always put to the second line, mainly because of its metabolic side effects. So any combination with olanzapine, either depression or mania, mixed episodes you can give. Carbamazepine is given as an alternative in BiPo. Right, so I think I can make it 14 minutes to go. So maintenance treatment. I don't want to delay your lunch. So, so NICE 2014, lithium is a drug of choice. So lithium is an effective, add valproate. If lithium is poorly tolerated, consider valproate, olanzapine, and quetiapine if it was effective in the last episode. Some of the trials have been like that. If your last manic episode was treated with quetiapine, continue quetiapine. If your last depressive episode was treated with quetiapine, continue quetiapine. Let's move to PAP. Lithium is the first choice, best overall evidence. And they say out of the ones, good evidence to prevent manic relapse is lithium, olanzapine, quetiapine, risperidone long-acting, and valproate. Preventing depressive relapses, lithium, quetiapine, and lamotrigine. So you can see it's only lithium and quetiapine that have good evidence for preventing both manic and depressive. So lithium, BAP says this talk of lithium being lithium monotherapy being gold standard, they don't agree with that. They talk about more combinations in bipolar. And combinations prefer to monotherapy. And if manic polarity, they talk about lithium plus antipsychotic or valproate, 2 antimanic agents if the predominant manic polarity. If it is a depressive polarity, again, 2 antidepressive agents, lithium, lamotrigine, quetiapine are the preferred ones. Olanzapine also comes into the picture there. So BAP prefers the combinations. Clozapine, if it is effective for refractory mania, can be continued. ECT, maintenance ECT has a place when medications are not effective. And of course, they talk about adjunctive psychotherapy for subthreshold symptoms. CanMat 2018. Now, there's an interesting point which I want to highlight here in CanMat guidelines. They talk about an increasing evidence to suggest that for a subgroup of patients, bipolar affective disorder may be a neuroprogressive illness in which recurrences are associated with reductions in brain gray matter and white matter volumes, worsening cognitive impairment, decrease in inter-episodic recovery and functioning, a higher rate of and severity of relapse, and a reduced rate of treatment. So this is not what we were taught when bipolar had good functional inter-episode functioning. We know clinically that not all bipolar patients are having good inter-episode functioning, and that's what they're talking of, a minority of bipolar patients. So they talk of first-line monotherapy or first-line combinations. Once again, CanMat considers lithium as the gold standard. So again, it's up to the clinician to decide whether to go for monotherapy or combination. If it is monotherapy, lithium, quetiapine, valproate, and they have brought in lamotrigine and aripiprazole as maintenance agents first line, which is not in keeping with the BAP, because lamotrigine, as you know, is mostly effective against depressive relapse, and aripiprazole probably against manic relapse. So, but they are brought in as monotherapy. And combinations is mainly quetiapine with lithium or valproate, or again have aripiprazole with lithium or valproate. So maybe that's what they are saying. They are looking at not just the they're looking at more all the aspects. But they don't, unlike BAP gives evidence for everything, CANMAT doesn't give really explanations why they put this here, right? Whereas BAP would give it. So maintenance in CANMAT, second, as I said, olanzapine again down to second. And also they have brought risperidone long-acting injection, which is the one that we thought had the evidence. They brought it down to the second line. Aripiprazole long-acting is the first line. And paliperidone is effective more than 6 milligrams. And the combinations are there. Right. Now the Australian guideline, the new one, takes a more holistic approach, and they say maintenance, the emphasis is on appraisal of the illness course and formulating a preventive strategy. So they say to study the illness course, predominant polarity of the illness, the pattern of the illness, is it, and the prior responsiveness and the current precipitant. So this is in graphic form, the pattern of the illness, whether it's punctuated or perpetual, predominance, and the prior response, and the precipitant, before you come to decision about your maintenance preventive strategy. So once again, if you read the RANSAP, you realize that they prefer monotherapy, mainly of the less side effects, and mood stabilizers are preferred to antipsychotics. So their first line is again lithium. So you can see even after so many years, lithium remains number one in most of the guidelines for maintenance. Quetiapine and valproate. And here they little different. Aripiprazole long-acting if there is a manic polarity. Not aripiprazole long-acting if there is a manic polarity. And lamotrigine only if there is a depressive polarity as monotherapy. Of course, the combinations are there, lithium with quetiapine, valproate with quetiapine, and lithium with valproate. Lithium with aripiprazole. So it's in graphic form. So you can see if it is monotherapy, if it is manic polarity, aripiprazole, lamotrigine if it is depressive polarity, if it is both, otherwise if you go with lithium, quetiapine, valproate. Combinations are aripiprazole, lithium and quetiapine and valproate. If there's a manic polarity, you might add aripiprazole. Alternatives, they have given alternatives. Again, always olanzapine comes second line nowadays. So that's a mood stabilizer. Carbamazepine and olanzapine are monotherapies. If there's a manic polarity, risperidone comes in. And of course, there are so many other combinations that you can go with. Some of these guidelines recommend that you exhaust all the first line combinations before you go to second line. So, I mean, if you try to do it practically, you'll be treating the patient for years and years before you try ECT, right? So don't take this literally. I mean, you need to take it practically. So I just thought, talking a little bit of rapid cycling, BAP says, when we were trainees, we were told that valproate was better for rapid cycling, I remember, but there's nothing like that in these guidelines. They say to identify and treat hypothyroidism, substance use, consider tapering and discontinuing antidepressants, and there's no specific treatments for rapid cycling. That's what BAP says. CANMAT says the same thing, but they add that rapid cycling may need combination of mood stabilizers. Long-term antidepressants. Now, is it BAP says and don't use antidepressants as monotherapy, but long-term antidepressants are effective in a minority of patients. And BAP says that some guidelines have gone too far in prescribing antidepressants long-term. Whereas in individual patients, if the patient, once you stop the antidepressant, if the patient continues to relapse to depression, there is a place for long-term antidepressant therapy. And they are asked to use the clinical judgment. Right. And finally, discontinuation of long-term treatment. Just want to point out what BAP says. Following discontinuation of medicine, the risk of relapse remains, even after years of sustained remission. So they really don't recommend discontinuation even after many years of sustained remission. If you do discontinue, that does not mean you discontinue engagement with the patient. You need to continue to engage with the patient and monitor the patient for relapse. Okay, so I've done in 25 minutes, so we have 5 minutes for questions. Okay, I hope I didn't confuse you.
Hello.
Hello. Thank you very much, Sajivana, for giving us a comprehensive description of all the 4 guidelines in a nutshell. So it's very nice and very important for all of us, mainly for trainees. So I would like to give this 5 minutes for discussion.
I mean, this is a question because these are really guidelines which have been made by different organizations. I mean, I have always felt that bipolar depression is so different from unipolar depression. And that we can see this in the treatment settings, isn't it?
Yeah.
I mean, bipolar depression, if it responds to treatment within a week or 2, you know it's not your treatment. It is the nature of the mood disorder which keeps changing. So I mean, I wouldn't take it all that seriously if you see rapid response. But I mean, again, quetiapine, for example, we know. I mean, most studies show that it's effective. But have you ever found a patient Sri Lankan patient who tolerates this range of 300 to 600 milligrams of quetiapine? I haven't found it.
If I may add something, sir. Now, if BAP says that quetiapine randomized control trials, actually it should be a little downgraded. Because they have compared quetiapine 300, 600 with placebo, and they say there is clear unblinding. Because if you give one group quetiapine 600 and the other group placebo, unblinding will occur because you know which one is creating quetiapine.
Yes.
So that those trials need to be downgraded a little.
The other thing, fact which I will mention is the use of valproate, because I mean these are more recent findings. That is, both carbamazepine and valproate increase the suicidal risk. So in bipolar depression, one has to be very careful in using valproate. And that is far better to stick to lithium. But I don't find this in recent practices that people are using lithium over valproate. People seem to play safe and use valproate. And say valproate is clearly a suicidogenic agent. And you have to be extremely careful in the use of bipolar depression.
Yes, sir. Thank you very much,
Thank you, sir.
Yeah, I think Dr. Tilak Ratnayaka wants to have another comment.
Hi, Sanjay. Thank you very much for comprehensive summary of the guidelines. I have a comment and a question. The comment is, as you said, the guidelines are guidelines, especially the NICE guidelines. People are debating whether it is clinical excellence or political excellence. So, especially for the trainees, you should know what are the guidelines, but don't stick to the guidelines. What I would suggest is, better way is what actually you are practicing in your ward is the main way. If your consultant or if yourself prescribing something, have a rationale why you are prescribing this, rather going by the guidelines. And in UK, now you can't prescribe sodium valproate or semi-sodium valproate for any woman if the patient is only you can prescribe if patient is requested. So sodium valproate is out for many of the patients. When it's come to the ECT, if patient has capacity and refused, then nobody can give ECT. If patient has no capacity, still consultant can't give the ECT until you get the second opinion. So my question is, if you have a patient in front of you, say 27-year-old, 3 months pregnant lady with hypomanic episode, what you would do? Because what kind of treatment plan you can formulate? If you go through the guidelines, you will really get stuck. So you need to practically think and do it, isn't it?
Yeah, hypomanic episode, I would go with a second-generation antipsychotic or an antipsychotic, even a first-generation antipsychotic, which is safe in pregnancy. If it is a hypomanic episode, 3 months pregnant. I mean, I won't have much. I don't know whether sir will agree with that.
Probably olanzapine will be taken.
I would use olanzapine or haloperidol or what we have. Are you okay with that? Yeah, because I don't think all the olanzapine is second line. We are not going to. I mean, that is mainly because of the metabolic side effects. They have taken it down.
Yes.
I don't think if you just use olanzapine for 6 weeks, patient is going to be diabetic. I mean, of course it can, but as long as you're careful,
Yeah.
that is not an issue. Because I think when we formulate these guidelines, we overplay certain things.
Yeah.
Like cognitive therapy in NICE guidelines.
Yeah.
I mean, CBT comes into everything.
Yes.
I don't need to expand on that
Yeah,
anymore.
that's it.
Yeah. Dr. Pabasari.
Yeah.
Please.
Yeah, and by the way, tradies, Dr. Ratnagiri is going to be your external examiner, so remember what he says.
Excuse me. Yeah, can you give this to Dr. Pabasari? Yeah.
I've let out a secret of the PG, I hope Shayan doesn't mind.
Sajeevan, congratulations on a very comprehensive review.
Okay.
Yes, before Paba, I'll just take a quick question. I think it's important to get the right dose of and get the right plasma concentration of both valproate and lamotrigine. Most of the failures in my clinical experience is I use inadequate lamotrigine dose. We should strive for 200 milligrams of lamotrigine, that is the recommended dose.
Yeah.
And valproate also, we need to find the right the dosing.
For what? Valproate? What do you mean?
Acute mania and as well as maintenance.
Maintenance,
Both,
okay. Yeah, the lamotrigine, as I told you, the underdosing of lamotrigine has been noted in the guidelines, in the BAP and the RANSAP. That's why the underdosing. Of course, whether it can be used in a very acute depressive state is a problem because you need time to build it up. You need time to build it up.
Thank you. I think Dr. Pabasari wants
Pabasari,
to...
Yeah, I'll just make it very quick. First, congratulations, only you can do this. Wrap up in this 25 minutes. Thank you. And I'm just throwing this question to all my seniors and my colleagues mainly. I mean, let's face it, let's be honest. Bipolar depression, I think all of us have to go for antidepressants. So I think the most important takeaway message in bipolar depression management is know your patient. See what has happened in the past, the relapses, the precipitants, stressful life events coming, then you know your patient, then play it according to the patient, taking what your chief examiner is going to be also said. So, and this Quetiapine, I agree with Dr. Ranlabi Singh. Quetiapine, sir, more than anything, I have tried Quetiapine because every guidelines harp on it, but then I'm yet to find a patient who got better only on even 300 to 600 doses who can really afford in our country. So,
okay.
Tough game. Thank you.
Time for lunch, I think. We can wind up for the session today.
So I am not
Thank you very much, Dr. Sajivana Amarasinghe, for your enlightening lecture. So I think we have to handle. Yeah, Sajivana. Be on the stage, Sajivana. There is a small token of appreciation. You can hand over the certificate.